Welcome to Lesson 2, where we will focus on cannabis use disorder. And the verse guiding this lesson is from 1 Peter chapter 5, verse 8. Be sober-minded, be watchful. Your adversary, the devil, prowls around like a roaring lion, seeking someone to devour. Cannabis is an addictive substance, and individuals who have a cannabis use disorder are not being sober-minded, and because of the focus on frequent use of cannabis, they become distracted from often from following God's will or plan for their lives and living up to their potential. Marijuana, otherwise known as cannabis, is derived from the cannabis sativa plant, which is available worldwide. And there's actually quite a large amount of use. It's estimated that globally over 166 million people use cannabis. And it is certainly known by other names besides marijuana, such as weed, ganja, reefer, pot, and it's very controversial, even though it is widely available around the world and frequently used. It is illegal. It's a federal law that it's illegal to use marijuana. However, medicinal use has been authorized in some states. So some states have made marijuana legal. Some states have also authorized recreational use of marijuana. Regardless, it still remains a federal law. And it is addictive. So even though there are some medicinal uses and purposes, cannabis in and of itself is highly addictive, and so can have some medical as well as psychosocial consequences, which we'll talk about. And it is often referred to as the gateway drug, meaning that it is a substance that leads to even more harmful drugs down the line. Marijuana is currently classified as a Schedule I drug, meaning that it is illegal to use and that it's highly addictive and has no medicinal purposes. If you remember, that's the meaning of a Schedule I substance. But it's been around for a long time, actually appeared around 4,000 years ago in China, was used for clothing, rope, and paper, and used early on in the US for these purposes as well. There have been documented use of cannabis for medical and spiritual ceremonies over the years, and it was included in the 1870 US Pharmacopoeia that identified its medicinal purposes. Now, marijuana is the Spanish word for the cannabis plant, and in the early 1900s, there was increasing controversy about its use and a lot of racial tones in the country, and some in the media blaming the Mexican immigrants for bringing marijuana into the country, as well as African Americans. Those two cultures had higher frequency of cannabis use, and so it actually was causing quite a bit of controversy. Early government research, however, indicated that there was not evidence of addiction or problems, and that there were actually potential health benefits. In 1924, the International Opium Conference did label marijuana as a narcotic and recommended strict controls. And in 1940, it was removed from the U.S. pharmacopoeia and a tax was assigned to the sale of marijuana. At this time, it was still legal and just taxed in the U.S. In 1970, the Controlled Substance Act passed and classified marijuana as a Schedule I drug. And as we know, Schedule I drugs are indicating that there is not any medical use for the substance and that it is highly addictive. In 1972, it was recommended to decriminalize marijuana possession and use. And it was found that people of color were 4 times more likely to be arrested for marijuana than Caucasians, even though both groups use the substance. In 1999, the Institute of Medicine did validate some potential medical benefits of marijuana, but also highlighted some of the negative aspects, which we will talk about. Cannabis contains many chemical substances, but it is the delta-9 tetrahydrocannabidiol, or THC, that has been identified as the primary compound that produces the high that occurs when smoking or ingesting it. Though cannabis has some medicinal purposes, the research is mixed on the effectiveness and which compounds other than THC might have benefits as well. So additional research is needed in this area. However, some concerns have come up. One is the use of synthetic cannabinoids, which are things such as K2 or spice. And those have been very dangerous, and kids having some very serious reactions to them as well. As well, there are some health effects of inhaled cannabis. It certainly can cause COPD as well as lung cancer. Marijuana is currently used in a number of different ways today. Previously, it was usually dried and then rolled into cigarettes or into a pipe and smoked. Different parts of the plant have different concentrations of THC, and use of resin or hashish as well as hash oil are actually increased. And the amount of THC is very high in some of those. The amount of THC in street sold marijuana is much higher today than previously, as cultivating techniques and hybridization has been used. So the potency is a lot higher and has been getting higher over the last 20 years. So smoking still remains the most common, though today it is frequently vaped using a vaporizer device. Now, another approach is edible cannabis. Edible cannabis is becoming more popular. It is less psychoactive. Actually, as it goes through the GI system, it takes longer to produce the high. But medical marijuana often is used this way in various edible, such as drops or gummies or other such edible products. Synthetic cannabinoids have been sprayed on plant materials to produce a synthetic marijuana. And some are potent CB1 agonists that have effects similar to cannabis, but it is less reliable and many more side effects and adverse effects. And here's a picture of some of the paraphernalia. You see several pipes that are used to smoke marijuana. It is frequently rolled with cigarette papers into a joint, and also cigars are used, hollowed out and then refilled with the cannabis plant, and that is referred to as a blunt. And here we also see additional paraphernalia. So the effects of smoking marijuana are more immediate, within 1 to 2 minutes, and lasting about 4 hours. PO, intake ingestion of edibles, usually will take at least 30 minutes before the effects end after 6 hours, so a little longer lasting. Some of the general effects are the producing of a general euphoria, relaxation, laughing, appreciation for music, an enhancement of the senses. Now, there can be negative reactions as well, such as the experience of anxiety, fear, paranoia, panic, hallucinations, and then just losing a sense of time. Now, marijuana is not harmless, and sadly today, with the legalization of marijuana and medicinal marijuana, we do have, I believe, a younger population who's not as aware of some of these negative effects. But it can cause a dry mouth. It can cause stimulated appetite. I've certainly had a number of patients who are on medical marijuana reporting significant weight gain from it. It can be antiemetic at lower doses, and so the stimulation of appetite and this antiemetic effect are very helpful for patients that are going through chemotherapy. But at high doses, it can cause nausea and vomiting. It dilates blood vessels, and this is the cause for red eyes. It causes an increase in heart rate, and as well can cause orthostatic hypotension. There is impairment in cognitive ability as well, with decreased attention, decreased short-term memory, and then interfering with complex cognitive abilities as well as motor abilities. Some effects of long-term use of cannabis include impaired cognition with forgetfulness, memory issues, attention, problem solving, and decreased mental flexibility. And there are changes that have been identified via neuroimaging and altered brain function in the prefrontal cortex, the cerebellum, and the hippocampus. The endocannabinoid system consists of several cannabinoids and cannabinoid receptors that synthesize and degrade endocannabinoids. Cannabinoid receptors, CB1 receptors, are located in high concentrations in several areas in the brain, and they help to mediate the psychoactive effects of cannabinoids. There are actually two cannabinoid receptor subtypes, CB1 and CB2, and 5 endogenous ligands. The psychoactive effects of cannabis are mediated by the CB1 receptor, and it's very abundant throughout the central nervous system, but especially in the brain, in the highest concentration in the basal ganglia, which you know is the center for the reward and as well learning and motor control. It's also in high concentrations in the cerebellum, which controls coordination, the hippocampus, which is why memory can be impaired, and as well the cortex, which may be related to the disinhibition. There are changes in brain activity following the administration of THC in these areas, and they are noted to be dose and time dependent as well. The euphoric effects are related to the THC enhancing dopamine neuronal firing in the reward pathway of the brain. Research findings have certainly validated harm from cannabis use on the developing adolescent brain. Cannabis use, either alone or in combination with other substances, can negatively influence normal neurodevelopmental processes. It can affect and impair executive function as well as working memory. There have been evidence of physiological changes on the brains of adolescents with regular cannabis use, including decreased cortical thickness and possible decreased myelination. The evidence base is available to support additional harmful effects of cannabis use on the developing adolescent's brain. As well, there are many other harmful effects for adolescents with regular use of cannabis. They have been found to be more likely to try other substances and develop substance use disorders. They also are identified as having poor academic performance. Many drop out of school. Many have more delinquent behaviors, psychiatric problems. There are more frequent emergency room visits. And it's been identified that adolescents with regular use of marijuana engage in risky behavior such as drugs driving, driving under the influence, and have a higher incidence of sexual transmitted diseases. Studies have identified an association with using cannabis and the increased experience of psychotic disorders. There has been a link of cannabis with schizophrenia, identifying a higher risk for the development of schizophrenia when there is an early onset of cannabis use or frequent use of cannabis. Patients with schizophrenia often engage in nicotine or marijuana use, and it does have a negative effect on the course and treatment of schizophrenia, and as well some deleterious effects on cognition. Even though in 1944, the New York Academy of Sciences stated that cannabis did not lead to addiction, but in 1999, the Institute of Medicine did declare that addiction was a problem associated with cannabis. And cannabis addiction is similar to any other substance addiction. It activates the dopamine reward pathway. There are some genetic determinants for cannabis use disorder, similar to alcohol. And stopping use causes a clinically significant withdrawal syndrome that's similar to tobacco withdrawal. Quitting can be very difficult. The use of cannabis can cause impairment at the social, behavioral, and emotional level. And even though it may be a less severe syndrome than some other substance use disorders, it still is impairing, and it does decrease an individual's function in many ways. The prevalence is growing as use of marijuana is increasing, and also starting at earlier ages. Cannabis withdrawal can be very difficult with extreme anxiety, and it is usually experienced by heavy users. And the symptoms do subside when using some THC. And the withdrawal syndrome begins 1 to 2 days after stopping and lasts for 1 to 3 weeks. While there aren't any major medical or psychiatric consequences of cannabis withdrawal, inpatient treatment can be very effective at preventing relapse. Additional symptoms of cannabis withdrawal include irritability or anger, sleep difficulty, decreased appetite, a depressed mood, and some physical symptoms even with stomach upset, tremor, headache, fever, chills, or sweating. Now, while cannabis is addictive, most users do not develop a use disorder. Only about 9% of cannabis users will develop a use disorder, as compared to 15% of cocaine users and 25% of heroin users. There are, however, an increasing number of patients with cannabis use disorder, and that number is growing with the availability of medical and recreational cannabis. As well, the increased potency of some of these preparations is linked with the increase in the development of use disorders as well. Daily marijuana use in teens is increasing steadily in some countries, such as the US and Australia, and use is higher among high school students in states that permit medical marijuana. The number of teens who think marijuana use is harmful is decreasing because of the availability and laws regulating recreational and medicinal use. However, admissions to treatment centers for primary cannabis use disorder have been dramatically increasing as well. There is a need for effective and easily accessible treatment specifically for cannabis use disorder, especially for adolescents. In the US, over 40% of treatment admissions for cannabis use disorder are for persons under 20 years of age. Cannabis has long been described as the gateway drug because it usually precedes use of harder drugs such as cocaine and heroin. And frequent cannabis users have a greater probability than non-users of using heroin or cocaine in their lifetime. Studies have shown high comorbidity rates of cannabis use disorder with other substance use disorder. And this raises the question of whether cannabis use is causally related to use and misuse of other substances. Cannabis use typically precedes other drug use, but so does tobacco and alcohol. Recently, it's been more apparent that the timing of the ingestion of the use of various substances can vary geographically and by culture, as well due to drug availability and societal factors. And There is thought that cannabis is a gateway substance as well because of the neurobiological effects of cannabis, that it can increase the sensitivity to the desirable effects of other substances. As well, use of cannabis can impact cognitive function and decision making, and thus affect the individual's choice of whether to use or not use other highly addictive substances. Neighborhood and conduct factors are indicated as well. So how do you assess for cannabis use disorder? Well, similar to other substance use disorders, and of course it should be included in the diagnostic interview in your substance use inventory. There are evidence-based screening tools, such as the Cannabis Use Disorder Identification Test, CUDIT, and as well the Cannabis Problem Questionnaire. These are available in adult as well as adolescent versions. There's a marijuana screening inventory as well that can assess patterns of use and help to identify clinical cases. SBIRT, of course, is a very useful approach. And as you recall, we use the CRAFT inventory to assess for substance use with adolescents. And here is the CRAFT. C, have you ever ridden in a car driven by someone who is high? R, do you ever use marijuana to relax? A, do you ever use marijuana by yourself or alone? F, do you ever forget things you did? F, do your friends or family tell you you should cut down on marijuana use? And T, have you ever gotten in trouble while using marijuana? Of course, craft can be used to target use of any substance, but it works very well for this. Of course, diagnostics include drug testing of urine as well as serum and hair. And testing for evidence of recent cannabis use is an important screening tool. And marijuana metabolites are very long lasting. So there are some inexpensive dipstick methods that can provide qualitative results, meaning a yes or no, in 2 to 5 minutes. There are some other more specific tests that can as well be quantitative, and saliva and hair specimens can also be used. Just like other substance use disorders, individuals dependent on cannabis typically will use the drug several times a day, and they may have some denial as well as some ambivalence about the negative effects that are associated with their cannabis use. Treatment interventions are similar to those used for any other addictive process. So we have individual or group cognitive behavioral therapy, and a combination of cognitive behavioral therapy and motivational interviewing can be very effective. Also include a contingency management program or some type of community reinforcement, and that can be positive reinforcement for negative tests. And multi-system therapy or multi-dimensional or strategic family therapy is very important. As we know, addiction does not just affect an individual, but affects the whole family. And so support for the family is necessary and can include also self-help groups such as AA or NA, Al-Anon, or Nar-Anon. Like other substance use disorders, individuals often do not seek treatment on their own as they do not see that it is a problem. And so with adolescents, it's often the parents who are initiating treatment. And so again, some type of contingency management with an incentive positive reward, a program for abstinence, as well as behavioral approaches such as initiation of contracts and weekly cognitive behavioral therapy and motivational interviewing sessions are often needed. And here's an example of a behavioral contract that can be initiated with your adolescent client and their parents. And it basically is stating that if the adolescent's drug screen is negative, that the parent will praise their progress, will ask how they can help them to keep up the good work to prevent relapse, and to celebrate their progress by, and then list some rewards. These incentives should be established with the adolescent, ideally. And if the teen's urine drug screen is positive, there would be some consequences that also would be stated. And in the contract, it states that if the drug screen is positive, the parent will remain calm, not give a lecture, ask how they can help them, express confidence that they can do better next time, and use the following consequence. And here might be listed things such as loss of privileges, such as phone or car use, things like that. Both the parent and the teen and the provider should sign the contract. Treatment can be delivered either inpatient or outpatient, and treatment can include a clinic-derived incentive program where a negative urine test does have some type of reward as well, increased privileges, and parents do need to also utilize breathalyzers to monitor alcohol use as well. Some individuals with a cannabis use disorder can develop a replacement alcohol use disorder if they see that substance as not being detectable as easily as the cannabis. And so again, the parent-delivered contingency management program is very important, and it needs to provide clear and consistent consequences, and they do need to be reinforced. If the consequences are not enforced, the contingency management program becomes ineffective. Just like all substance use disorders, prevention is the goal. And prevention of cannabis use disorder is important. SBIRT can be a good approach. Having conversations and talking about the risks and harms of cannabis use with youth is important. There really are a limit to the available treatment centers for adolescents with substance use disorder. So strategies really need to be to increase perception that cannabis is harmful, because it is, and especially so, even more so for the adolescent brain. Parent education and training is needed, but it does need to be balanced, science-based, and rational. So not using scare tactics. And school-based intervention programs can be helpful, school-based prevention programs and educational programs. Targeting educational programs for high-risk youth is helpful as well. Medical marijuana use is highly controversial, and the legality of it affects the teen's perception of risk. There is some evidence for some of the compounds of the cannabis for medicinal purposes. The FDA has approved a drug, Marinol, that has a synthetic THC, and as well, Nabilone is a generic name for a synthetic cannabinoid that's similar to tetrahydrocannabinol, and it's an active ingredient in the FDA-approved drug Sesamet. And so certainly we have these drugs that have been approved. However, medical marijuana, because marijuana remains a Schedule I substance, healthcare providers and prescribers, according to the DEA, cannot prescribe medical marijuana. So physicians and nurse practitioners cannot prescribe marijuana, and only a certifying physician can certify a patient for use, and then the patient goes and purchases their medical marijuana. So it's not a prescription. It's not a dosage, that's been identified for that patient of a particular type of preparation. So all the doctor is doing is certifying that the patient has a determined qualifying condition. And each state's medical marijuana program has a list of the qualifying conditions. So I encourage you to look at the state of Florida and see what the qualifying conditions are. And again, a medical marijuana physician has to go through training to be able to be certified as a medical marijuana physician. Advanced practice nurses cannot certify patients for medical marijuana in Florida. There are some states where they can. Florida is not one of them. And again, the doctor is not prescribing the marijuana. All they are doing is certifying or authorizing that this patient does in fact have multiple sclerosis or any other condition that is listed on the state's qualifying condition site. Now, again, smoking marijuana versus oral use, it is much more highly psychoactive from smoking. So again, the effects are quick, they're not as long lasting, and there are those adverse effects from smoking. There also is increased intoxication from use when it is smoked. So most medical marijuana is available in oral preparation, such as sublingual drops or other edibles. Let's take a look at both sides of the controversial issue related to legalization of marijuana. On the pros side, it is found to be less harmful than alcohol use. And there is thought that regulation or a tax of the sale of marijuana could provide fiscal benefits and as well quality control to ensure that the substance is safe. The addictive potential is considered to be lesser than other substances, and as well with a legalization of marijuana, there will be reduced crime and consequences connected with its use. There are medical benefits such as the treatment for pain, eating disorders, or appetite problems, as well neuromuscular or neurodegenerative diseases and autoimmune disorders. Now we have to counterbalance that with the cons, however, and the cons are that there are psychosocial, health, and psychiatric consequences. We talked about some. So certainly the increased risk for psychotic disorders, for developing a dependency, for weight gain, for COPD or cancer with inhaled use, and as well, legalizing marijuana is already showing an increased use connected with it. Many illegal drugs do have medical benefits, and legalizing marijuana could reduce the perceived harm, and so perhaps more individuals who could benefit from the medicinal use could potentially access it. And again, another con is that driving under the influence of marijuana is found to be just as harmful as driving under the influence of alcohol when in an intoxicated state. So, in conclusion, misuse, abuse, dependence, and withdrawal connected to cannabis use are very real and very common, and they are especially problematic for adolescents. They are similar to other substance use disorders in that they will impair their function at work, home, and school, and some level of cannabis use does have harmful effects. Many users have significant consequences. There is new research, but of course we need more research on the development and treatment of cannabis use disorders.